This explainer is based on Anxiety-Related Dizziness, a Vestibular Physician's Deep Review of Panic Disorder, Generalized Anxiety, and Hyperventilation Syndrome, published by Australian Dizziness Clinics.
Welcome back to our Explainer series. Today, we're building the pharmacotherapy algorithm for anxiety-related dizziness. We'll be outlining exactly how to start, titrate, and switch medications to get the absolute best outcomes for your highly sensitive vestibular patients.
Now, right out of the gate, we have to tackle a massive clinical paradox with this treatment. The very pills meant to cure the dizziness will actually make it worse for the first 2 weeks. Why? It's due to that initial serotonergic activation. Understanding and managing this paradox is absolutely key to your treatment success. So let's map out the exact decision tree for your next patient consultation. We're going to cover 1. Our first-line SSRI strategy. 2. The first fortnight paradox. 3. The titration and maintenance timeline. 4. Escalating to SNRIs. 5. The benzodiazepine bridge. And 6. Multidisciplinary stepped care. Okay, let's jump straight into part 1. First-line SSRI strategy, the starting line. We have to begin with the foundation of our pharmacological management, which is targeting the underlying anxiety disorder with first-line agents. And let's be clear, vestibular suppressants, they are totally inappropriate here. We need treatments that address the actual mechanism at play. Now, here is a crucial clinical pearl. You must start SSRIs at exactly half the standard anxiety dose to improve tolerability in these highly sensitive patients. So whether you choose sertraline at 25 milligrams a day or escitalopram at 5 milligrams a day, starting low is literally critical. And what's super interesting is that these SSRIs don't just treat the anxiety, they actually have a direct additive serotonergic action right within the vestibular nuclei and inner ear. Which brings us to part 2. The first fortnight paradox, managing early worsening. Heading into those crucial first 2 weeks, we hit a predictable hurdle. And honestly, this can completely ruin adherence if we don't manage it properly as clinicians. You must actively warn your patients about this transient dizziness caused by that initial serotonergic activation we talked about. Because if you don't counsel them in advance, they're predictably going to stop the medication prematurely. They'll come back to your clinic completely convinced that the tablet made their condition worse. So the psychoeducation here is just as important as the prescription itself. Moving right along to part 3, titration and maintenance timeline, the clinical journey. Once we successfully navigate that rocky first fortnight, we can map out the longitudinal life cycle of the prescription to set really clear expectations. So you start on day 1 at that half dose. Then you titrate up at 2 to 4 weeks while simultaneously kicking off vestibular rehabilitation therapy and CBT alongside the drug. You'll want to review their response at the 6 to 8 week mark. That's our true therapeutic window. If it's successful, you maintain this dose for a strict 12-month minimum before you even attempt a slow, planned taper. That time is essential to allow sensitized central networks to adopt. Now, if a patient has an inadequate response at that critical 6 to 8 week review mark, you don't want to just guess what to do next. Instead, you follow a stepwise, evidence-based approach to safely manage their care. That leads us perfectly into part 4, escalating to SNRIs, when SSRIs aren't enough. For those patients still facing severe or refractory panic symptoms despite our first-line efforts, we need a really clear evidence-based escalation pathway. If the response is inadequate, you escalate systematically. First, raise the SSRI dose. Second, switch the SSRI. Third, if that fails, you move to an SNRI like venlafaxine, dosing between 37.5 and 150 milligrams a day. Its dual noradrenergic activity can be highly beneficial here. And finally, you can augment the primary medication with agents like buspirone or pregabalin to target any residual anxiety. Next up is part 5, the benzodiazepine bridge, strict rules of engagement. We absolutely have to address the most common pharmacological pitfall in vestibular medicine, the widespread misuse of vestibular suppressants. There is a hard line here, folks. While serotonergic agents like SSRIs and SNRIs actually promote central compensation and help the brain adapt to vestibular signals, chronic benzodiazepine use does the exact opposite. It reinforces avoidance behavior, it generates dependency, and it completely blocks vestibular compensation. In fact, the withdrawal symptoms from chronic use often mimic the very dizziness you were trying to treat in the first place. Now, if you absolutely must use agents like clonazepam for severe anticipatory anxiety or maybe acute panic attacks while waiting for the SSRI to kick in, they are a strict short-term bridge for 4 weeks or less. And this is crucial. You must communicate a clear taper plan to the patient from day 1.
Finally, we reach part 6, multidisciplinary stepped care, the ultimate ladder. We really have to place our pristine pharmacotherapy algorithm inside a broader, holistic framework. Because, let's face it, drugs alone are rarely the complete answer. Treating anxiety-related dizziness effectively means treating both axes simultaneously on this stepped care ladder. You start with psychoeducation to reduce fear, use your half-dose SSRI strategy, and then combine the drugs with VRT and CBT. These non-drug therapies aren't just little add-ons. They actively address the 3 maintaining mechanisms: vestibular sensitization, catastrophic cognitions, and avoidance behavior. Using this combined approach is exactly how you reach that impressive 60 to 75% clinical improvement rate. So, how exactly do we deploy these non-drug therapies alongside our prescriptions to truly heal these complex patients? Well, join me in our next explainer, Non-Drug Therapy, Prognosis, and Controversies, where we close the series by diving deep into CBT, VRT, outcomes, and the open debates in the field. But before we go, as you reflect on this algorithm, ask yourself, how many of your chronic dizziness patients are currently trapped behind a benzodiazepine blockade, and are you ready to guide them out? For additional resources, including the full literature review, clinical cheat sheet, and patient leaflet, visit AustralianDizzinessClinics.com. And please, subscribe to support the channel. See you next time.